Next, we're going to have Professor Tin Leong. He's going to talk about the year in reviews of the GI endoscopy. I believe that no needs for very much introductions about Professor Ang. Briefly, he is international leaders in the GI fields, not only the GIs, but also GI endoscopy. He also is our important member for the Bangkok consensus leaders, and we're going to have a new consensus together very soon. Professor Ang, please.
Good morning, ladies and gentlemen. First of all, I would thank Professor Vaucha and Professor Ratakon for their very kind invitation. It's always a great pleasure for me to come back to Bangkok and take part in this very important meeting. I've been given a daunting task to review the literature for the last 1 year in the field of GI endoscopy. And actually for endoscopy, it actually covers several disease states. And therefore, what I've done is to go through the published literature and select what I think are probably something important. I try to cover concepts that encompass training, that encompasses diagnostic imaging, endotherapy, and also maybe the way we should reconsider our approaches in terms of endoscopic evaluation and treatment. So let's just dive in right now. So I've sort of categorized my talk into upper, lower, endoscopy, ERCP, EUS, and also sustainability in endoscopy. I think, first of all, I'd like to highlight that recently our APAGE consensus on surveillance for H. pylori associated gastritis has been accepted for publication in GUT. It looks at the issue of pre-malignant conditions and how we should tackle this problem. What's important to highlight is the fact that we should actually perform high-quality, systematic endoscopic evaluation in order to ensure that we can pick up any discrete lesions, in order to make sure that we can properly do an endoscopic risk stratification to guide our surveillance strategy. And also, this guideline actually gives us some recommendation in terms of how often we should perform endoscopic surveillance. One point I'd like to highlight is that there's a bit of difference compared to the Western guidelines from Europe, from America, which were also published this year. We actually advocate that we perform surveillance every 2 years in patients with advanced atrophy and IM. In contrast to the MAPS-3 and also ASG guideline where they suggested we do so every 3 years. And the reason we recommend it 2 yearly is because of the concern of cancer dysplasia evaluation within a 2-year period, which is based on prior studies. Another point to highlight is that even for patients with mild IM, mild gastritis, if they do have additional risk factors such as a strong personal history, smoking and so on, we also suggest that maybe we perform surveillance every 3 years. So it's important for us to know about this guideline because firstly, this represents the first Asian Pacific approach towards this common condition. And secondly, there are some subtle differences with the West because I think sometimes localities do matter in terms of how we approach a disease state. I think we all know that upper GI bleeding is very common, and despite the multiple advances that have happened in this field in terms of acid suppression, in terms of endotherapy, it still remains an important clinical challenge and problem. And one of the issues will be how can we perform endotherapy more easily because we can't have an expert endoscopist be on call every day at night. So, and therein comes in the issue of hemostatic powder. So in this year, the ASG actually came out with a technical review on the different powders that's available, and they sort of summarized the basis for how the powder work and the preliminary data to date. And essentially, we all know that the powder work by providing a mechanical barrier that sort of stop bleeding. And one constant concern will be what happens when the powder sloughs off the next day, the day after, would then therefore bleeding recur. But we also know from old studies published by I think James Lau and his group that if the body actually plays a very important part in the healing process, because I think in some early studies done long ago, they performed endoscopy at different point in time after bleeding, and they showed us clearly that the ulcer morphology changes from high risk to low risk over the course of time, and that's because of the body's natural healing process. So maybe powder may be enough just to stop the initial bleeding, and we can then move on to either continue conservative treatment while letting the body heal by itself. So this year, there were 2 randomized controlled studies that looked at 2 newer powders, both from Korea. In, I think, GI endoscopy, we have this powder that look at CEGP 003. So the authors performed a randomized controlled study using powder as a first-line treatment option for non-variceal, essentially ulcer bleeding, compared to traditional treatment modalities such as clips, ablation, and so on. And you can see from the figure here that the immediate hemostasis success rate was actually similar between both standard therapy and powder. And this is somewhat similar to some extent with James Lau's study was published, I think 3 years ago in Annals, but with one important difference. This study focused purely on ulcer-related bleeding, whereas James' study also included patients with tumor and non-ulcer bleeding. But one point to note would be the fact, despite this immediate hemostasis success rate being similar, patients do have a higher recurrent bleeding rate with time. And I guess this does remind us that ultimately, this is still a major concern that hasn't been adequately addressed. But I suppose if we look at it from another viewpoint, it does buy us time in terms of maybe a more experienced endoscopist can then do a second look endoscopy and KIV perform repeat endotherapy, or we can arrange for a next step treatment such as IR-guided angioembolization. So I think what's important to note would be that immediate success rate is the same and it buys us time, whether or not to let the body heal by itself with no further bleeding, or we perform repeat scope and by a more experienced endoscopist, and therefore we go on to secure the hemostasis success rate over a longer period of time. Another study that used a next powder looked at the use of powder as an adjunct to non-variceal GI bleeding. So all these patients had the immediate hemostasis secured using current traditional methods, and then after, the next powder was applied to the treated ulcer base. And this study showed us clearly that in this context, it actually reduced the risk of rebleeding. I guess you have to ask ourselves, the rebleeding rate is actually rather high in this study after endotherapy, whereas we tend to think that a successful treatment would actually lead to a much lower rebleeding rate. But I guess the take-home message should be the fact that if you're concerned that your endotherapy may not work that well, then certainly by applying a powder as an adjunctive treatment modality, maybe we can actually further reduce the rebleeding rate for this higher risk group of patients. So let's change track and we moved on to the lower GI tract. I think we ended the year 2024 with this RCT from Australia that compared a cold versus hot snare EMR for large, flat colorectal polyps. We have all been using cold snare to resect polyps smaller than 1 centimeter. And when we do so, we can actually get a good, nice margin on block resection with a high success rate with low recurrence. And the idea then was to push the frontier a bit further and use a cold snare resection in larger lesions, maybe by piercing resection, and to see whether it can perform as well compared to hot snare. The underlying driving force was actually to reduce the adverse event rate, because without using cautery, just using the sharp snare to resect the lesion, we do away with the chance of maybe delayed bleeding, delayed perforation from thermal injury to the gut wall. So that was a driving concept. And in this study, they showed that the immediate success rate was similar, but a recurrence rate was higher in the cold snare EMR group. But what's important that they highlighted was the fact that maybe using cold snare, we have less severe adverse events. So perhaps it's a safer alternative when one weighs the decision between increasing efficacy versus decreasing adverse events. In this year, this topic was readdressed by two randomized studies. I think one was from Germany, another was, I think, from Europe. So what's important would be to highlight the fact that both studies were consistent in the fact to establish the fact that certainly when we use a cold snare wide field EMR, it does increase the risk of lesion recurrence, because even if we try to do overlapping resection, we try to resect the margin of the base. The depth of resection using cold snare is actually ultimately still more superficial than hot snare. And there could be microscopic foci that ultimately predispose to lesion recurrence. But what's important to note that in both studies, which are randomized controlled study, the severe adverse event rates were actually similar. So cold snare did not actually give us a higher safety profile margin compared to hot snare. So I guess what we can take away from all these three studies will be the fact that firstly, hot snare is probably more effective in terms of reducing long-term recurrence, and therefore it reduces the need to repeat endoscopy, and maybe it can help us reduce our carbon footprint. But at the same time, for selected patients, we may still well want to do cold snare if we really, really think that the risk of bleeding, risk of perforation is very high or not acceptable for that patient profile. But literature will tell us right now, based on these studies, that there's actually no difference in the safety profile for both modalities. We move now on to ERCP. First, I'd like to touch on about training and how we can train better so that we help our juniors overcome steep learning curve. So if we were to have taken 1 year to learn a skill, I think as the educator in this day and age, we should help them to maybe learn it faster, if possible, to maybe half the learning time and so if it's really, really feasible. And that's why using realistic training models for simulation is very important. So simulation by itself is good as a concept, but if the model is not realistic, then it probably will not help the trainee at all. But if we were to adopt a realistic training model, such as the one highlighted here, this Podgorski-Kostamagnia trainer, it essentially it creates the artificial papilla and offers quite realistic training condition for a trainee to practice intubation, cannulation of the bowel duct. So this randomized controlled study actually split the trainees into two groups. One group had, for the first 3 months, they have 2 days of intense simulation training using this model. And in the other group, they just go by the traditional training methods in terms of proctorship, in terms of apprenticeship kind of training. You watch your trainer do, you try, and so on. So this study actually shows us that if we were to use this training model, this simulation model, it actually helped to improve the training experience. It helped to improve the success rate in terms of cannulation and so on. So I guess it's something that we need to look at, when we start procedural training, especially for advanced procedures where it is challenging for the trainer to let the trainee do too much, especially if the risks are a bit higher. But at the same time, we need them to accumulate a realistic experience so that they can proceed further in their technical ability. So having a realistic training model is something very important, and we should consider adopting in our training curriculum. For ERCP, the most important aspect is actually selective duct cannulation. So if we cannot selectively cannulate the duct that we want, we can't do further diagnostic procedure or therapeutic procedure. And this is a study published by Vinay Dear and Amit Medio from Mumbai, India. It looked at 2 ways of cannulating the bowel duct in patients with a malignant biliary obstruction. One would be if, let's say, the cannulation was difficult, they either do a pre-cut tracheotomy, which is essentially to use the needle knife and just cut open the orifice, make it bigger so that we can selectively enter the bowel duct, or we actually perform a US-guided rendezvous procedure whereby a linear echo-endoscope is used to visualize the bowel duct. The bowel duct is punctured, the wire is inserted through, and then through a rendezvous approach, the CBD is cannulated. So this study shows us that both options are actually comparable. But of course, to use US-guided cannulation can be more challenging, and it might be easier for trainees to master pre-cut rather than US-guided intervention. Another study I want to highlight is that a lot of time we are taught to do papillotomy before insert the metal stent. Maybe you can reduce the chance of severe complications such as pancreatitis because then it doesn't occlude the pancreatic orifice. This RCT shows us clearly that such an idea maybe is just theoretical because in real life, it doesn't decrease the risk of pancreatitis, and therefore to reduce the risk of pancreatitis, we need to consider other alternatives such as rectal NSAIDs, hydration, and so on. I need to rush a bit because time is getting short. So I think one point I want to highlight is that the rule of US-guided gastroenterostomy to palliate a malignant gastric outlet obstruction. I think traditionally it had been surgery and then we had metal duodenal stenting, but in recent years, US-guided drainage has come to the fore, and it offers an advantage in terms of bypassing the tumor site, therefore reducing the risk of tumor ingrowth. And maybe it can be as long-lasting as surgery. So this year, 2 studies were performed. One, both for RCT, one compared US-guided drainage with duodenal stenting. And in this first study, it showed us that the need for reintervention was actually lower when we perform US-guided drainage compared to duodenal stenting. So therefore, certainly if patients are expected to survive longer, we should consider US-guided drainage rather than duodenal stenting. And the second study from Europe actually showed us clearly that US-guided drainage was similar in terms of long-term outcome compared to surgery. And it allowed the patient to commence oral intake faster. So and therefore, if the expertise is available, we should seriously consider performing US-guided gastroenterostomy. I come to the last part of my study, of my presentation, about this very important topic of sustainability. And I'd like to highlight this year, Apache actually published its position statement on the importance of sustainability, and it gave certain recommendations of what the clinicians can do. And also we have a white paper from ASGE that sort of summarizes the steps you can take to green our endoscopy unit. And actually some of these steps are very simple. This was a quality initiative, I think from Europe, and it showed us that simple education intervention can help us reduce waste because then endoscopists will not use so many accessories, and therefore this can actually cut down waste, cut down our carbon footprint, and yet not affect outcome. I'd like to highlight that a lot of time we try to do a simple procedure thinking that maybe we can get away with it, we can reduce the risk and so on, but sometimes if we try to do a more thorough procedure the first time around, like say we do a complete resection of a flat lesion compared to a piecemeal resection, we are more sure of a cure, and therefore we can actually reduce our clinic visits, reduce the number of endoscopy, and this can also translate into being a more sustainable approach because it cuts down carbon footprint from repeat visits, from repeat transport, and so on. So this is something that we need to be mindful of. And with this, I thank you for your attention.